Yes, so hello, I'm Dr. Nicolas Farina. I'm Associate Professor in Dementia Research at the University of Plymouth. And today I'll be talking through a program of work where we were implementing a community dementia screening program in rural Kenya. The project is called DEM-SKY. So in Kenya, what we generally see is that when people start to recognize symptoms of dementia, so cognitive and functional impairment, there are three common pathways to a dementia diagnosis, or should I say, a lack of a dementia diagnosis. So the most predominant and common pathway that we see is that most people will perceive the symptoms being a normal part of aging. So this is a common perception that's held, and therefore, because they see dementia as a normal part of aging, no further action is taken. So this obviously leads to lots of people uh, living with dementia, often not receiving the support that they may need. The second pathway is to consult a spiritual healer. So the spiritual healer may give, may correctly identify that as a medical condition, but it can also lead to the attributing symptoms of dementia as being due to witchcraft, which obviously is very stigmatizing both um, to the individual and may isolate them within the community. And then finally, we have this third pathway, which is a kind of a lot smaller. People can receive a diagnosis through private clinics, but obviously that requires having the resource to be able to access it, or through primary healthcare. And so really what we wanted to do within DEM-SKY is, I suppose, is to encourage more people from the first two strands, so people who weren't going to receive a diagnosis and those who may have gone to a spiritual healer, and encourage them more through the, let's say, the more kind of official healthcare systems. And so this is where the DEM-SKY project comes in, where essentially we wanted to develop a pragmatic mechanism of trying to kind of shift people into that pathway. So essentially, we provided community healthcare workers. So these are people who are working on in the community on a day-to-day basis. They talk to people for a whole range of reasons in the community, such as raising awareness about vaccinations and so forth. And so really, we wanted to give these community healthcare workers the knowledge and the tools to be able to screen dementia in the community. So there's less of those barriers to having to kind of go to having to travel to a hospital, for example. And hopefully this then kind of cascades into people having the kind of receiving that screening, being aware of what the outcome is, and then going to seek a formal diagnosis if they need to, and ultimately being able to receive the treatment and support that they may need. So the study itself was in McWinney County, so it was a opportunistic sample of older adults living in a very predominantly rural region of the country. And we wanted to, we asked the community healthcare workers to use a brief CSID tool. So this is a short cognitive tool composed of cognitive and functional outcomes, lasts probably 5 minutes in total. And essentially all of the older adults that went through this process, they received a letter about saying whether they've screened negative or screened positive for dementia and what that may mean, and and whether they should, given the information about the local health settings, to receive a diagnosis if they so wish. But alongside that, we also took kind of questionnaires and did some interviews to find out a bit more about some of these implementation outcomes. And in general, the preliminary evidence suggests that it was relatively successful. So we managed to screen 3,500 older adults within a 6-month period. Prior to the outset of the study, we set a pragmatic target of 1,600. So that was to say that if we didn't reach that number, then we would consider the reach being a failure. And so that almost, this number kind of is about 3.8% of all older adults in the region. So that shows a pretty good reach for such a short period of time. We also found that older adults were generally quite confident about the screening outcome. So that's obviously very useful, because if the older adults didn't see that the screening outcome was accurate, then they're unlikely to action. There's unlikely to be behavioural change. So that's also very positive. And we also see that near 100% of the times, at least, the community healthcare workers were saying that they adhered to the dementia screening process as it was set out to them. So obviously we need to explore a bit further about those few instances where they didn't adhere to it, but that's something for the future. The older adults generally said that they found that it met their approval, that they liked the dementia screening, and that they welcomed it. So generally that's all kind of really good signs. So that the fact of the matter is that the dementia screening wasn't automatically distasteful for those that went through that process. As I referred to before about that kind of process about causing that change in those pathways, we also looked about behavioral intention. So we found that 89% of the people who screened positive said that they were likely to speak to a doctor in the future versus 23% who said that they screened negative. So that's, so it's still positive that there are some people who, even after screening negative, they will still consider speaking to their doctor about the outcome. But possibly more useful information here is that we weren't able to follow up this cohort long term, but what we were able to do is we were able to look at the local referral hospital who would normally see people with dementia if they had symptoms of dementia. So the previous 6 months prior to the DEM-SKY project, they were seeing an average of 6.5 people per month. And during the DEM-SKY project, they were seeing close to 40 people per month. So obviously that's really, showing that actually the dementia screening led to a change in behaviors and an uptake, or at least that's what it appeared to be. And, through interviews with healthcare professionals, they were saying similar things. They said that they noticed that people were coming through with these referral letters. And actually there were people who hadn't been screened for dementia, but they were also coming to the hospital because they spoke to other people and on the basis that they started to recognize that symptoms that they may have had wasn't due to normal aging. And I suppose that's something that's come up quite a strong message, is that even the older adults that screen negative, they almost treated that the screening program as a way, they kind of gained understanding about what the symptoms of dementia, and that actually they noticed that going forward that they would go to a hospital for a checkup if they did start to see that they had those symptoms. So that's very positive. Obviously, there's some questions about moving forward, because obviously we want to ensure that it's sustainable, particularly in a low resource setting. We also need to be considerate about how, whether these the healthcare professionals in the hospitals have capacity and have sufficient training to ensure that they can meet to this increased demand. And finally, I suppose we also need to ensure that those that do go into the healthcare systems are then receiving the healthcare and support, the post-diagnostic support that they need. And hopefully this is something we can pursue long-term in a future study. So yeah, thank you everyone for your time, and I'd like to thank you all the collaborators in Kenya who've worked on this project, as well as the Davos Alzheimer's Collaborative who funded the project. Okay, thank you.